I'm Dr. Ann Kellams. I am a professor of pediatrics and director of the UVA Breastfeeding Medicine program at the University of Virginia School of Medicine in Charlottesville, Virginia, USA. I'm going to talk for a couple minutes about artificial nipples and nipple shields and what I feel like I wish every physician knew. So for nipple shields, I don't use them often. I don't recommend their use often. And they certainly shouldn't be introduced until there's been a very skilled feeding evaluation of both the mother and the infant together and looking and assessing for the effectiveness of feeding. And certainly after trying multiple things to manage whatever issues they're having. So it's sort of a last resort for me. Some of the times we think about using it would be with premature babies who are really learning how to suck to begin with. And it's sort of like training wheels. Some babies are very sensitive to having their palate stimulated. And so depending on the mother's breast and nipple shape and size, they may be getting to the breast and simply not getting any signal on their palate whatsoever to help trigger suckling. So sometimes that can be useful. Occasionally, we will use it for babies who have a very strong bottle preference and for whatever reason prefer that to going to the breast. And it's sort of a way to kind of trick them at the breast and give them this familiar silicone plasticky feel that's a little stiffer than the typical mother's nipple, and then can get them interested and sort of let the light bulb go off that, oh, there's milk here at the breast. Occasionally, I will see patients where there has been so much nipple damage and trauma that they really can't even think about trying to put the baby to the breast. Occasionally, we'll just have to give some healing and have them expressing milk in another way. But sometimes there's a willingness to practice with the protective shield. So while the baby is learning good technique, there's not further damage to the nipple. And then occasionally for the same thing about triggering the palate, there will be a particularly flat or inverted nipple and a baby who's particularly prone to desiring that palatal stimulation. We will use the nipple shield in that situation. So here's a question for you. Is this true or false? There's no such thing as nipple confusion. Well, I will tell you that I have come to believe that this is actually true. And it's because in the years of experience and just watching, thousands and thousands of babies, they are not confused when they're deciding they'd like to eat one way or the other. In fact, they have a really strong preference. So some babies from birth will just go back and forth between breast and a bottle nipple, no problem. But some babies really care greatly which way they are eating. So it's a really strong preference. And the problem is you don't know you have one of these babies until there is a problem. So as much as possible, particularly while breastfeeding is getting established and in the first couple of weeks, we would recommend trying to avoid artificial nipples. The other thing I want you to be aware of is a technique called paced bottle feeding. This is probably not a bad idea whether or not the baby's ever going to feed at the breast or not, and whether or not they are exclusively formula feeding. So it's been shown that babies that drink even their mother's milk out of bottles will take in more milk than they would have had they been at the breast. And it's also been shown that the larger size of bottle that you use, the more milk a baby ingests. So it means that something's going on with the dynamics of bottle feeding where the fluid or the volume is getting into them quicker and maybe even more than they need. So in addition to thinking about physiologic volumes, if you're using the bottle for supplementation, we want you to pay special attention to the technique as well. So if you have a baby that is bottle feeding for whatever reason, and the end goal of that family is to get the baby feeding at the breast, then we recommend doing cue-based feeding or responsive feeding, and trying to set up a situation with the bottle where the infant is controlling the flow with their own suckling activity. We want them to preserve skills that are the most similar to breastfeeding. So while the bottle nipple is stiff, We do not recommend just sticking it in their mouth. We recommend, rather kind of signaling, touching their upper lip, getting their attention, having them root around, and only putting the bottle nipple in their mouth when they open really wide. So that's step one. So they've got to root around, open wide, then something goes in their mouth. And then rather than the picture here where the baby's leaning back and the bottle's sort of pointing down into their mouth, where gravity is going to be helping the flow of that liquid, what we want is either the baby to be sitting upright or lying in the parent's lap and have the bottle be horizontal to the floor. So tilt it just enough so there's milk in the nipple, but only baby gets milk when they are suckling. So when they stop suckling or take a break, we actually recommend tilting it down so that they learn, okay, so I've got to root, I've got to open wide, something's going to be in my mouth, and then when I start suckling, and only then will I get milk flow. So we don't recommend, putting milk in their mouth and getting them to suck. In fact, we want them to learn that they go to the breast first, they suckle, let down reflex is triggered, and then they get milk.